In this video, we'll talk about the odontogenic keratocyst, which is very commonly asked question. So first of all, it is a cyst which is derived from remnants of dental lamina with a lining of distinctive lining of 6 to 8 cells in thickness, exhibit a basal cell layer of palisated cells and surface of corrugated para-keratin. Okay, so the basic keywords that you will have to remember is, first of all, it's the remnant of dental lamina, then it is 6 to 8 cell, then it is showing palisated cells and corrugated para-keratin. Now coming on to the other names, it is also called as the primordial cyst, then it is also called as benign cystic neoplasm, then it is also called as keratocystic odontogenic tumor. Now, why is this called as a tumor? Now, this is a topic which is usually a controversy, you can say. Sometimes they shift it into the cyst and sometimes into the tumor. This is because it shows a high recurrence, mitotic activity is very high, and there is aggressive clinical behavior. Okay, now coming on to the epidemiology, age, it is seen in second to third decade. Now in the sex predilection, it is more in males. At the site, it is usually seen on the angle of the mandible. So first of all, mention that it is more in mandible, then in maxilla, then it occurs more in the mandibular angle region, followed by the third molar region, then the ramus of mandible. Okay, now coming on to the etiology. Etiology is basically what I call as origin, right? So first of all, we mentioned remnants of dental lamina, so just mention that dental lamina remnants, then basal cell layer of oral epithelium, then basal cell nevus syndrome. Now this syndrome we will discuss later, right? And one more origin, which is the primordium of developing tooth zone. Primordium. Now let's talk about the clinical features. First of all, a very important feature is it is asymptomatic, right? So what you will see is there is the bony expansion is minimum, right? It is really not visible to the eye. That is why is it so? Because it expands in the interior posterior direction. What do I even mean by this is, suppose this is the mandible. Okay, now usually what you will see is, if there is a cyst and it is going to enlarge over here, so it will increase this length, right? But what about OKC is, what it does is, suppose this is the mandible again, suppose it started here and it spreads on like this, so there is this much swelling, right? And it is in the bone, so you really cannot see it and it is not quite evident, but it grows to a large size. Okay, also, yeah, then it is going to displace the adjacent teeth. Now it is painful when secondarily infected. Now it is more prone to fractures, also because it's spreading in the mandible more, so mental nerve paresthesia can occur. Yes, there will be one tooth that will be missing. Now, this is seen more in dentigerous as well. Okay. Now, let's talk about the syndromes that are associated. First of all, just remember mango. Oh, okay. So, M stands for Marfan syndrome. As I tell you about Marfan, you should be reminded of Abraham Lincoln. I'll tell you later when we cover the bone pathologies. E for Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is basically when the skin is very stretchy. It is basically the person who has Ehlers-Danlos syndrome. He's called to be a rubber man. So N stands for the nevus or the Neumann syndrome. Yes, and G stands for the Gorlin Gold syndrome. Now, what? Now you must question why we did not mention the nevus, basal nevus syndrome. So because it is the another name. Okay, O stands for OKC. Now coming on to the radiographic features. Now just remember this diagram, and you are done for the radiographic features. Okay. First of all, what you will do is you will mention about the unilocular or multilocular radiolucency. That gives a characteristic honeycomb appearance or sunburst appearance or soap bubble appearance. Then any swelling, just write expansion and cortical perforation. Okay. Now, if it is what you can see is it is scalloped, right? Also, it can cross the midline because it is spreading antero-posteriorly. Now, one more thing. Usually, what defines a cyst is the aspirate that it gives. So, cystic content. In OKC, because of the keratin, what you will see is there will be a dirty, white, cheesy material. Okay, the protein content is going to be less than 4 gram per deciliter. And one more thing, that there is no odor. Okay, in histopathology, we will talk about just remember, wait, just let me draw a diagram. I do not have my histo pencils around, so I'm just drawing it with my pen. um, yeah, so this will take me a little bit of time. Just draw this similarly over here. Okay, so first of all, what you see is this thing, right? We will go like this. So what is this? This is basically the corrugated parakeratin. Now parakeratin will be more than orthokeratin, but orthokeratin can also be present. Then what is this? This is basically the odontogenic stratified squamous epithelium. Do you see any retipex? No. So absence of retipex. Now very characteristic and something that you need to remember. This is basically in a line, right? And the nucleus is away. So this is basically something like this. Now you must have seen this in gardens. So what is this? This is a picket, right? This marks the boundary. So the cells are also like this. So we can tell that the palisaded cells, they have a picket fence appearance. Picket fence, or even remember the tombstone, like that as well. So tombstone appearance. Okay. Then there is a lot of small microcyst. Another name of microcyst is satellite cyst. Okay, so yeah. Now, coming on to the differential diagnosis, you can label it as lumen, corrugated parakeratin, palisaded nuclei of basal cell, then epithelial lining of even thickness, connective tissue capsule. Now, in differential diagnosis, because it is occurring and there is one missing tooth, so you can mention about dentigerous cyst. Then it is also going to resemble the radicular cyst and ameloblastoma. Why ameloblastoma? Because of the picket fence appearance. All right. Now, what is the reason for recurrence? This is a very important question which is usually asked. So, to remember this, just remember pics that. Okay, fixed it. So by P, remember there is the uh, by P you can remember the pattern of keratinization. Then I, incomplete enucleation of original cyst. C stands for cystic penetration into jaw. Then another C for cortical perforation. S stands for the satellite cyst. D stands for the dental lamina residues. I stands for, we have already covered I. T stands for thin and fragile lining. Alright, now we will discuss the treatment. Now in treatment, there is enucleation plus there is curettage. Now you're often asked the difference between the two. Enucleation is basically the removal of cystic lining. Removal of cystic lining. Whereas what is curettage? It is basically we mechanically removal of 2 to 3 centimeter of bone around cystic cavity after curettage. Okay, this is very commonly asked in vivas as well. You must remember. Then after this enucleation curettage, there is we can do decompression, enucleation plus curettage. Then we talk about osseous resection. Now, what is osseous resection and when we have to do it? Basically, in this, what you do is you resect the part of bone. Now, to remember where you do this, just remember crap. Okay. So C stands for when it is having condyle involvement. R, recurrent lesion. A, ameloblastomatous or basically carcinomatous. P, when there is pathologic fracture. Now let's talk about the adjunctive methods. Now in adjunctive methods, the first one is the Carnoy solution. You are often asked this in the viva in oral surgery, but just to add some more marks, so you can mention about it. It has the composition of 60% ethanol, 10% glacial acetic acid, 30% chloroform, and 1 gram of FeCl3. This is not put now because it causes the chemical necrosis. Then second is cryosurgery. Now what is cryosurgery? We will cover it in the general surgery part, but in this what you use is you use ammonia at freezing temperatures and you basically freeze the cyst along the wall. Now due to this it is easily removed. Then we also perform peripheral ostectomy. So this is the treatment. Also, I forgot to mention about various types of odontogenic keratocyst. So I'll just mention it here. It is the replacement, then collateral, then we have the extraneous, and envelopmental. Now, what do I mean by all these? Replacement, when it will replace one whole teeth, replaces one whole teeth. Collateral, between two roots. Extraneous, away from tooth bearing area. Envelopmental, basically encircling the whole tooth. Okay. Yeah, this is like, this is our cyst. Okay, in this, and in extraneous, you can remember it as away from the tooth bearing area, so basically here. And in envelopmental, you will think of something like enveloping the whole tooth. In this, basically this is going to get replaced. So this covers the odontogenic keratocyst. I hope you understood. I tried to make as easy as possible. Thanks for watching.